This patient is going to be demonstrating a high steppage gait. So this patient has a steppage gait on their right side. You can tell that the patient is unable to dorsiflex their right foot. And this causes a high steppage gait. The patient will need to bring their leg up higher than normal. It is often caused by foot drop due to a loss of dorsiflexion. It is also in association with damage to the deep peroneal nerve. When you're unable to move your anterior leg muscles, which help dorsiflex the foot, you're going to need to compensate by doing a high steppage gait so you don't trip over yourself.
So why should dorsiflexion fail? So here are your dorsiflexors. We remember them by this formula. The Himalayas are not dry places. Tibialis anterior, extensor hallucis longus, this is tibialis anterior, this is the extensor hallucis longus, extensor digitorum longus and peroneus tertius. The Himalayas are not dry places. These are the dorsiflexors. So if dorsiflexors are weak, the patient will not be able to dorsiflex the ankle, the tibio-talar joint. Then, if plantar flexors are tight or spastic, you will still not be able to dorsiflex. Now, they are tendoachelis, plantaris, posterior capsule, which has got a tibiocalcaneal component, a tibio-talar component, and a talocalcaneal component. So, if there is a contracture here, then the patient will not be able to dorsiflex the ankle, and this condition, since he will not be able to even passively dorsiflex the ankle, this condition is called as equinus. And this, of course, is called as foot drop. Absence of active dorsiflexion is foot drop, and also absence of passive dorsiflexion is called as equinus. Equinus, foot will remain plantar flex even on weight bearing, and in foot drop, foot will fail to dorsiflex only in the swing phase. Now, supposing we try to manage the equinus first, because first we must be able to, if there is inability to passively dorsiflex the leg, it can be either because of spasm, which is treatable by proprioceptive neuromuscular facilitation, or because of contracture. So if it is because of contracture, you will do a tendoachelis Z-plasty, you will resect the plantaris, and you will remove the tibiocalcaneal capsule and not the tibio-talar capsule, because you do not want to destabilize the ankle. But still, you may not be able to dorsiflex, and the reason for that is that the anterior portion of the body of talus is wider in front as compared to behind. So in the tibiofibular mortis, the tibiofibular ligament is contracted, and the mortis does not allow the wider anterior body to come into the mortis. So in this case, you may have to divide the tibiofibular ligament to be able to correct the equinus deformity. So after understanding this much about the equinus deformity, where passive dorsiflexion is not possible, if there is a spasm of the plantar flexors, you will do a proprioceptive neuromuscular facilitation, and the spasm is usually because of the upper motor neuron involvement. The upper motor neuron starts from the cerebral cortex and ends in the spinal cord. If there is a contracture, then you will give corrective plasters, you will do a tenotomy, you can do a tendoachilles lengthening by Z-plasty, you will resect the plantaris, you will divide the tibiocalcaneal ligament or posterior capsule, and you may have to divide the tibiofibular ligament to achieve correction of contracture. Now let us say that the passive correction is possible. How to achieve dorsiflexion? So why should this dorsiflexors be weak? Here you see the upper motor neuron, here. This is the anterior horn cell. Till it gets out of the intervertebral foramen, this is the nerve root. Then you have the nerve, then you have the myoneural junction, and then you have the muscle. So upper motor neuron we have covered, that will lead to spasticity and can be treated by proprioceptive neuromuscular facilitation. Then the anterior horn cell is involved in polio and motor neuron disease. The nerve root is usually involved in a disc prolapse, a spina bifida condition. That means abnormality of the development of vertebra. The nerve can be involved in an injury, which can be iatrogenic or because of a fracture. Then there will be mononeuritis, which is usually entrapment. Then there can be mononeuritis and involvement of multiple nerves, as in leprosy. And then there can be polyneuritis, like diabetic polyneuritis. In all these conditions, the nerve will be involved. The myoneural junction is involved because there is excess of choline esterase enzyme, which doesn't allow acetylcholine to persist in the synapse, and therefore after walking some distance the muscle start getting weak. So that is called as the fatigue test positive. So now then there is the muscle, and there can be what is called as the muscular dystrophy. So remember, anterior horn cell, nerve root, nerve, myoneural junction, muscle. So these can be all the causes of dorsiflexion, and you must learn how to identify them clinically and do appropriate investigations to find out why there is a foot drop. Now what happens with the foot drop? The effect of active dorsiflexion loss. The first thing that you have seen, that when this limb is swinging forward, dorsiflexion has failed. So this toe will stub the ground. To avoid this, the ankle is plantar flexed, but the hip and the knee will hyperflex. And because of this hip and the knee hyperflexing, these toes will clear the ground. They will not stub against the ground. So one feature is hyperflexion of hip and knee, which is called as the high steppage gait. The second thing that you must understand is that normally the foot leaves the ground in the swing phase on the toes and touches back on the heel. So this is normal gait, toe heel gait, but here the foot will leave the ground on the toes and touch back on the toes because the foot has failed to dorsiflex. So this is called as the toe to toe gait. On examination, you must detect dorsiflexion loss by gait analysis and by actively testing for dorsiflexion. You should identify the cause. Basically, the cause can be with or without sensory loss. You can understand that the nerve root and nerve involvement will be with sensory loss. The anterior horn cell, myoneural junction and muscle will be without sensory loss. You should identify associated contracture and try to correct it before you start to restore active dorsiflexion. You should identify the alternative motors that can be substituted for dorsiflexion. The dorsiflexors which are paralyzed are tendoachelis, extensor hallucis longus, extensor digitorum longus, and peroneus tertius. And the alternative muscles that can be transferred are EHL, EDL, tibialis posterior, peroneus longus. So these can be transferred. If the EHL and EDL are active, there will be cocking of toes, that means hyperextension at the metatarsophalangeal joint during the Singh phase. Then they can be used, they are the best transfers. But if they are not so powerful and there is a varus component, you use tibialis posterior, and a valgus component, you use peroneus longus. Before you do that, you must identify that there is ankle stability and if there is pain on weight bearing. Then you cannot really do a tendon transfer. Then you must find out whether the power loss is recovering or recoverable, or there is a residual loss. So these are the points on which you must be able to answer after you've done a thorough clinical examination. How do you find out whether it is recovering? You can find out by march phenomena, by motor march and nerve conduction velocity, by the SD curve going from galvanism to Faradism, by electromyography showing giant action potentials in the tibialis anterior, by Tennel sign. All these indicate that the nerve is recovering. So what do you do during recovery? You treat the cause, you maintain passive movement, do not allow a contracture, and for the recovering muscles, you maintain tone and prevent wasting by galvanic stimulation first, then by Faradic stimulation, then active assisted, active and active resisted exercises. Okay. In the residual, specifically when 9 months have passed, then the motor end plate is fibrosed and recovery will not occur. Then you must think of, first you must think of tendon transfer, because that restores active dorsiflexion. If the extensor hallucis longus is transferred to the neck of the first metatarsal and the interphalangeal joint is fused. This operation is called as modified Jones. Do the same thing with extensor digitorum longus, it is called as Hibbs operation. Now, if there is foot drop with varus, you take the tibialis posterior, the root can be circumtibial or interosseous, and the insertion can be into bone, into cuneiform, or into tendons EHL or EDL. Now, interosseous is better and insertion into bone is better. Now, then if there is valgus, you transfer the peroneus longus to the neck of talus. If you do only this, it is called as Osmond-Clark operation. But if you combine it with lateral graft into the sinus tarsi, it is known as the Grice and Green operation. Then, if tendons are not available, you do a bone block. You can raise this dicky of the talus, which will strike against the dorsal margin of the tibia and prevent foot drop, or you can sort of turn the upper part of calcaneum upwards. So again, when there is foot drop, this will strike against the posterior surface of tibia and prevent foot drop. So there is a talar block and there is a calcaneal block. But if you are doing a triple arthrodesis, then you remove the the inferior surface of talus perpendicular to the leg and the upper surface of calcaneum parallel to the plane of the sole, so that when you close this wedge with talus completely plantar flexed, the foot comes into neutral position. This operation is called as Lambert-Eames triple arthrodesis. Now, if the joint is painful and unstable, you fuse the ankle. You fuse the tibia to the talus. You can remove the talus, fuse the tibia to the calcaneum, or you may do what is called as the Blair's fusion, in which you remove the body of the talus and you slide an anterior graft into the neck of the talus. So this allows some degree of plantar flexion and dorsiflexion. This operation is called as Blair fusion. Thank you.